gland disorder, which is known as hyperprolactinemia. So the term itself is self-explanatory. It is actually a state of persistent serum prolactin elevation. So the normal prolactin level is mainly less than 20 microgram per liter. So if the patient prolactin level is above 20 microgram per liter, on multiple occasions, mostly there is a need of actually having the measurement on multiple occasions to be called hyperprolactinemia. But this is anyway the standard definition. A high prolactin level above 20 microgram per liter is the general recommendation to be called hyperprolactinemia. So when you look at the physiology of prolactin, prolactin is actually a very essential hormone, mainly for production of milk. So during childbirth, that is the principal role of prolactin. Of course, it has a role in the mammary gland development as well as even breast engorgement. Then mainly regulated, we have already discussed about the regulation mechanism of prolactin, but mainly it is regulated by hypothalamus pituitary axis, and it is produced from the anterior pituitary gland. Okay, then in normal condition, the secretion of prolactin is mainly controlled or under tonic inhibition of dopamine. That is how it is regulated in the body system. But however, if a patient is actually having maybe hypothyroidism, like increased hypothalamic thyrotropin releasing hormone can actually even stimulate prolactin level in primary hypothyroidism. That is why when the patient is having hypothyroidism, even high level of prolactin is a major finding. The probability is actually very high as a result of pituitary stimulation of thyrotropin releasing hormone. So it is good to note, by the way, in relation to primary hypothyroidism, the probability of infertility is very high as a result of prolactin elevation. Then, when you look at the epidemiology of hyperprolactinemia, it is very common during reproductive age, but generally speaking, the incidence is very low. And you can say about the estimated prevalence in the reproductive ages, like as high as 15 to 14.3%. Very common, but the incidence is not as such in the general population. Is very highly prevalent only in the reproductive age of female population. Then, what causes a high level of prolactin, or what are the major etiologies for high level of prolactin? There are various causes. Some of them are actually due to the physiological system, such as pregnancy, when you are in estrus, during sleep, sorry, and during even meal. The probability of high level of physiological prolactin level is very high during this condition. So, because of the effect of food on the serum prolactin level, the best time to measure the serum prolactin level is usually like after fasting for 8 hours. That is a general recommendation. But of course, some kind of tumors can actually increase the production of prolactin. For example, polycystic ovarian syndrome, which is very common in females of reproductive age. We call it even ovarian cyst, which is a common finding, and mostly it is actually resolved by itself, and there is no any treatment modalities having currently to manage this condition. Then pituitary tumors, when there is a tumor in the pituitary gland, the probability of having a high level of prolactin production is very high. So some kind of pituitary tumor can also increase the production. Then apart from that, when a patient is having hypothalamic prolactin stimulation, for example, in case of primary hypothyroidism and adrenal insufficiency, what will happen? Those deficiencies can actually activate the release of prolactin from the hypothalamus. So those are the major etiologies that can increase the serum prolactin level in the reproductive age. Apart from that, when a patient is having those chronic conditions like chronic renal failure, liver cirrhosis, there is a significant reduction in the prolactin level. So the clearance of prolactin is highly dependent on the renal system as well as the hepatic system. But when this system is actually deranged, the clearance will be reduced. So prolactin in the serum will be elevated significantly for a long period of time. So in that condition, even the patient can have even high prolactin level. And apart from that, when a patient is having breast stimulation, then breastfeeding, when a patient is having chest wall injury, even those are some of the neurogenic causes of high prolactin level. Then apart from that, of course, some drugs can also include the prolactin level, such as dopamine antagonists. So most of antipsychotics are targeting the dopamine receptor. And as we have mentioned previously, the prolactin level is mainly regulated by dopamine. So as long as we're blocking dopamine receptor, the probability of affecting the prolactin level is very high. That is why when a patient is taking with this class of drugs, there is high probability of having high prolactin level. Then apart from that, some class of drugs can also stimulate the release of prolactin, such as the serotonin reuptake inhibitor, gonadotropin releasing hormone analogs, and even tricyclic antidepressants and etc. So those are the class of drugs that can actually increase the prolactin level in the serum. So this is the major aspects or etiologies in terms of causing high prolactin level in the body system. So having said this much about the etiology of this condition, and now let us see about the pathophysiology. Generally, it is the most common endocrine disorder of the hypothalamus pituitary axis. It is actually very common on that area. And the major problem with this, when the prolactin level is very high in the serum, it can inhibit the release of gonadotropin releasing hormone from the hypothalamus. So what will happen if gonadotropin releasing hormones release is suppressed, then it subsequently lower the level of luteinizing and follicular stimulating hormone stimulation from the anterior pituitary gland. Then results this ultimately results in uh, reproductive dysfunction at basal galactoria. So when a patient is having high level of prolactin level, because of the effect on gonadotropin releasing hormone from the hypothalamus, the probability of having a reproductive dysfunction such as infertility and galactoria are very common conditions. So those are the most common finding when a patient is having this problem. Then in terms of clinical feature, mostly some people can have a local effect because of the effect of the tumor. For example, when we do have a prolactin secreting tumor, maybe in the pituitary, there is a probability of having headache and visual disturbance. I've already mentioned in the previous session, because of proximity to the optic nerve, when there is a tumor, it can actually even cause a blockage of the nerve connection to the optic nerve. So there is a probability of visual disturbance. So in female population, because of the effect on the gonadotropin releasing hormone, the patient can have amenorrhea, even oligomenorrhea, galactoria, infertility, and of course even hirsutism can happen. So those are the major findings when a patient is having high level of prolactin. So if you notice a patient is having amenorrhea, and oligomenorrhea, you just actually don't conclude to go hypogonadism because there are several causes that affect us or that can actually affect the menstrual cycle. Then, of course, men are also have prolactin level. So this prolactin level in men is mainly important in the spermatogenesis. Like it is important for testosterone production and ultimately for spermatogenesis. It is very important hormone. So like both in men and female, they do have the level. So in case if the level of prolactin is elevated in men, it can actually decrease libido, then it can cause infertility, then of course galactory and gynecomastia can be happen because of the effect of prolactin to the breast tissues. So those are some of the major clinical presentation when a patient is actually having uh, this serum prolactin level in the patient. So having said this much about the clinical picture, now let us talk about the investigation. So what are the major factors that affect the prolactin level? As I mentioned previously, some physiological factor can affect the serum level of prolactin. So because of this reason, it is actually too advisable to exclude those physiological parameters when we are measuring the serum level of prolactin. For example, avoid eating, like the patient is supposed to fast before you measure the prolactin level. Then avoid exercise because exercise can cause mild increment in the prolactin level. So because of this effect, it is good to actually avoid eating, don't avoid exercise before the test. So in general, the best time to do the measurement is at rest, preferably in the morning under fasting condition. So you just better take at rest in the morning as well as in the fasting state so that you actually exclude the physiological effect of the physiological effect to the prolactin level. So that is when we are going to actually do accurate diagnosis. So in short, to make an accurate diagnosis, obtain the prolactin measurement in the fasting state before breast stimulation and ultrasound. So this is the general recommendation when we're taking sample from the patient. When you look at the lab result, any question?
Yeah.
Okay. Huh?
I'm asking, like in the morning, during when people are fasting, isn't the level low?
So which no. Normally, eating, you know, why we prefer in the morning is like most people they don't eat food early in the morning. So like before they take breakfast, you take sample, then you measure. Otherwise, like fasting state will not affect the prolactin level, but what affects us is like diet. If the patient took meal means the probability of transient elevation and getting like abnormal or false result is very high. That is why they are supposed to take the sample in the morning hours.
Okay, thank you.
Yeah, have you seen even TV? Is there anyone who has done TV examination for sputum? Even they usually take in the morning. Yeah? Do you know why? Is there anyone who has done a TV test before? Okay, fine. I will ask you later. So, prolactin level at rest will usually above 20 nanogram per ml in men and above 25 nanogram per ml in women with at least three measurements. So, when the level is very high, like at rest, above 20 and above 25, this is diagnostic for hyperprolactinemia. But remember, you need to actually exclude other parameters such as pregnancy, primary hypothyroidism, renal failure, and etc. So those are the primary factors that can actually elevate the prolactin level. So obtain ECG to test to exclude pregnancy, then look at the TSH level to exclude any primary hypothyroidism. We have mentioned earlier, when a patient is having primary hypothyroidism, the probability of having hyperprolactin level is very high because of stimulation from the hypothalamus. Then exclude renal failure. Why are we supposed to exclude renal failure? Is there anyone, Angela? Why we exclude renal failure when we're actually measuring the serum level of prolactin? Hello?
I don't know. I'm not sure.
Okay, Annette?
Can you say, okay, I'm not sure, but you exclude renal failure because I'm not sure.
We already said, oh, that means here, you know, the major problem with online learning is most people will not concentrate when they're at home. So otherwise, we have already said, is there anyone who heard what we have said before? Why we need to exclude?
Because there is reduced renal elimination.
Yeah, because of reduction in the renal elimination. Of course, kidney is the principal organ to remove or to eliminate the prolactin in the serum, in addition to liver. But kidney is the principal route of elimination. So because of this reason, you have to rule out whether the patient is actually having kidney failure or not, so that you can actually exclude whether the patient is really having another or due to renal failure or due to other causes. Then, of course, CT scan and MRI can be used for tumor. If there is any tumor in the brain, that is very important to exclude. Yes. So, based on your observation, what do you think about the treatment modalities for hyperprolactinemia? How do we manage? I think by now you do have at least a idea what is hyperprolactinemia, what really causes, how do we investigate it, and what are the most common clinical presentation. So now, how do we manage hyperprolactinemia?
Dopamine agonist.
Dopamine agonist. Why we give dopamine agonist?
Because dopamine regulates prolactin levels.
Yes,
So,
dopamine is the principal, yes, the principal neurotransmitter that actually controls the level of what? Prolactin. Okay, so we can give dopamine agonist. Then any other treatment strategies? Any other? Maybe Kate, can you try?
Maybe removal of tumors in case there's a tumor in the pituitary gland.
Yes, exactly. In case if it is caused by tumor, the possibility of surgical resection is another possible approach. Okay, good. Then any other strategies, Juan Kitinji?
Not sure for the moment.
Okay, good. Thank you for your response. Then Tony?
Yes, sir.
So do we have any other strategies for management of this condition apart from what has been mentioned?
Can you say radiation?
Yeah, there is a possibility of radiation therapy. Yes. Okay, thank you. Then those are the strategies. But before that, or before we discuss to the treatment modalities, let us see about the goal of therapy. The goal is, the primary goal is we need to normalize the prolactin level, then improve fertility. That is actually very important, especially for a woman within the childbearing age. Then protect against development of osteoporosis. Remember, so maybe let me ask you a question. Is there any relationship between osteoporosis and high level of prolactin? That means if a patient is actually having high level of prolactin level, is there a probability of having a risk of osteoporosis? What is the relationship between the two? Laura, can you try? What is the relationship between, because one of the goal of therapy is just to protect against the development of osteoporosis. If so, was there any link between osteoporosis and hyperprolactinemia?
Can you say it has a okay, women who have hyperprolactinemia also have hypoestrogenism, so it causes osteoporosis.
Exactly. Thank you so much. So, as I mentioned before, when the prolactin level is elevated, it can actually suppress the gonadotropin releasing hormone, and ultimately, the gonads will not produce sufficient level of estrogen. Remember, this estrogen is actually very important hormone for the females, especially for bone development and bone remodeling. So ultimately, the net effect of estrogen is actually bone formation. So if estrogen production is actually suppressed, means the probability of having osteoporosis is actually very high. Because of this reason, one goal of therapy is protect against the development of osteoporosis is another treatment goal. Then treatment-wise, if the cause is actually drug, discontinue the offending agent. That is the primary modality of treatment. If the cause is actually due to antipsychotic or any other dopamine 2 blocker, we just give discontinue the medication. That is one non-pharmacological treatment strategy. Then transsphenoidal surgery and radiation therapy, what you have seen previously when we were discussing about acromegaly. So this one is mostly reserved to severely intolerant patients. Like if a patient is resistant to pharmacological modalities, maybe that is when we are going to consider surgery and radiation therapy. But in short, in terms of pharmacological treatment modalities, dopamine agonists are the front line for all type of patients when the prolactin level is elevated. So dopamine agonist is the front line in the management. So in the previous session, we have mentioned about the dopamine agonists, bromocriptine, cabergoline, pergolide. But this one is widely available in the local market, as I mentioned even in the previous lesson, and they are the main pharmacological therapies in the management of hyperprolactinemia. Okay, good. So why it is the principal pharmacological treatment in the management? Because dopamine is the principal hormone or the principal neurotransmitter that regulates the prolactin secretion from the anterior pituitary hormone. So when we are actually activating the receptor of dopamine, it can actually effectively inhibit or suppress prolactin release from the anterior pituitary gland. Because of this reason, dopamine agonists are the primary treatment of choice in the management of this condition. So you can actually even see when you look at the treatment outcome, they can reduce the tumor size in 90% of the patient. Normalize prolactin level, restore menstrual cycle, reduce tumor size in approximately 90% of the patient That is why they are very effective. So because of the side effect profile, mostly low dose is recommended from this dose range 0.625 to 1.5 mg at bedtime is mostly recommended. So you just actually titrate slowly until the maximum dose, because most of the time when we continue the treatment, most of the side effect will subside by itself, and mostly the side effect of bromocriptines are mostly associated with the GI discomfort. So those are some of the adverse effects you need to know regarding to bromocriptine, and the commonest are mainly CNS, like the lightheadedness, dizziness, nervousness, and headache. Those are actually quite common, by the way. Yeah? They are quite common, but still the patient can have GI side effects. So those are some of, and with continued treatment, most of the side effects will subside by itself. Then another type of dopamine agonist is carbapenem. So this one is a relatively higher affinity than bromocriptine for dopamine to receptor, and it possesses a long half-life time, by the way. Because of this reason, even if you remember what we have discussed in the previous class, it's usually given once or twice weekly administration because of long half-life time. And even ADR profile is more tolerated as compared to other class of drugs. So that is the beauty, and because of this reason, is more effective in normalizing prolactin level. So that is the special advantage of this class of drug as compared to bromocriptine. The slight limitation that is having with this class of drug is the probability of mild elevation in the liver enzyme. So it can actually affect the liver. So this is the doses 0.5 milligram per week or 0.25 milligram twice weekly can be considered in the management of this condition. So this is all about the pharmacological treatment modalities. But in terms of non-pharmacological treatment modalities, I've already mentioned about the role of surgery and the role of radiation therapy can be considered. But these treatment strategies are usually considered when a patient is actually having refractory condition for pharmacological treatment modalities. So especially non-prolactin secreting tumor that jeopardizes the optic chiasma, and radiation therapy can also be considered in case of failure. But the major problem with radiation therapy, as I have said before, it will take longer time to see the full effect. So because of this reason, it is not really commonly considered. Then apart from that, even radiation-induced permanent hypopituitarism is also another challenge with these treatment modalities. So this is all about the treatment approach of hyperprolactinemia in brief. Then let's see about management of hyperprolactinemia in pregnancy. That means like special population. So when you are thinking about pregnancy, what comes to in our mind is the teratogenicity potential of drugs. So whether they are actually crossing the placental barrier to elicit a certain teratogenic effect would be the major aspects of the pharmacy, what we are supposed to look at it critically. So currently, there are reassuring evidence about the low teratogenic effect of bromocriptine. So generally, based on that evidence, bromocriptine is not as such to affect the fetal malformation and to cause even preterm deliveries. And even carbapenem does not appear to be teratogenic despite limited experience with pregnancy. So far, there is no so much actually data about the safety profile of this long-acting dopamine agonist in pregnant mother. So despite those conflicting data, continuation of dopamine agonists during pregnancy is generally not recommended. So generally, there is no like adequate evidence about the safety profile of dopamine agonists. So in short, in pregnant mother, we don't really generally recommend for this patient population. But based on the available information and based on the experience in long-term experience in pregnant mother, bromocriptine will be the preferred treatment of choice if we are supposed to initiate pharmacological management in pregnancy when the prolactin level is elevated. But the major challenge with cabergoline is due to prolonged half-life. So if a mother is actually having a plan to be pregnant, even they are supposed to actually discontinue at least 1 month before planned conception. So remember, there is no it does not, so currently there is no known teratogenic effect of cabergoline, but still the experience in pregnant mother is very limited. That is why the mother is supposed to be notified to discontinue 1 month in advance before planned conception. So that is the recommendation. So in short, when the prolactin level is high in pregnancy, bromocriptine might be the drug of choice because of greater experience during pregnancy, despite the safety is not absolute. Okay, finally, how do we monitor treatment response? So treatment response is usually measured based on the serum concentration of prolactin, and mostly it is recommended 3 to 4 weeks after initiation of drug therapy. So to assess the efficacy and appropriately titrate the dosage, the patient is supposed to be on 1 dose of a drug at least for 3 to 4 weeks. Then after that, we can actually titrate. So this is the time we can see the full effect of the drug. Then after that, we can actually do, if the patient clinical pictures and the prolactin level is optimized, now it can be monitored every 6 to 12 months. So prolactin level measurement is one strategy to measure or to monitor the treatment response. Of course, the clinical parameter can also be monitored, and lastly, the size of the tumor can also be assessed after the treatment. So those are the strategies we can consider when we're managing this patient population. So in the next few minutes, I do have a case study for discussion. So maybe please get ready to go through the case studies in the next few minutes. So I give you 2 minutes to read the case studies. Maybe 3, yeah? 3 minutes so that we can do it together. Start from here. Okay, next slide. So who can give us the summary of the case study report?
Let me try.
Okay, thank you. Try, please.
It's about I don't know what her WB. She's just
WB.
27. She's 27 years old. She went to hospital and she was complaining of a discharge from both her breasts. She also said that her period has stopped since she stopped taking oral contraceptives, but before then her period was regular before starting the oral contraceptive. She didn't have any presenting symptoms apart from the discharge. So that's why we are being told she didn't have any weight change, no hair growth or acne. And we are being told she doesn't exercise excessively and she's otherwise healthy.
Okay, good.
Yeah. And
Then, is there any significant information from the history of the patient, family, past medical? Not significant, yes?
no.
Okay. Then next. Medication history.
We're being told she was on acetaminophen, which she discontinued, and acetaminophen.
Okay, good. Review of system and physical examination.
Normal. The examination shows that she has normal visual, like she has no eye problem. No, she's negative for goiter. Everything else looks normal.
Okay, except
apart from the breasts, yeah.
Yeah, but apart from the bilateral expressively galactoria with no other abnormalities. Okay, abdominal examination seems like normal, yes? Have you seen any finding from the abdominal examination? Abdomen is soft and tender and not distended, and there is a bowel sound, which is okay. No hepatosplenomegaly, and there is no blood in the stool. Okay, good. Then electrolytes and electrolyte level. Is there any derangement? Annie?
They are within normal limits. The only one which is elevated is prolactin.
Okay. Okay, good.
So
it's only the prolactin and she's not pregnant. Okay, good.
Yeah.
MRI shows?
MRI shows a pituitary gland, approximately 9 millimeters in diameter. Yeah. So that can be the cause, I think. Yeah.
So can you try number one? So based on this given information, what sign and symptoms does WB have for hyperprolactinemia?
Based on the information, we can see that she's complaining of the discharge from both her breasts, and yeah, that is the major sign.
Okay.
And the symptom, that's the major sign, and the symptom is the previous slide, something about. Can you go to the previous? Yeah, the after examination, we saw the bilateral that one.
Okay, galactoria.
Yeah.
Okay, good. Milky discharge is the symptom. Then the signs are the bilateral galactoria, and any other is elevated prolactin level. Those are the key. Yeah, those are the key. Then let me ask the other people so that they can actually wake up. Geoffrey? Geoffrey?
Yes, sir.
Can you hear? Okay. What is the essence of actually assessing renal and thyroid function when we are actually investigating hyperprolactinemia. Is it fair? You know, when you are actually ordering even lab requests, it has to be cost effective. So do you think it is rational to assess renal and thyroid function test when a patient is having this problem? And if so, why?
I think for the thyroid fund, it will be necessary.
Why?
Um, to check for levels of thyroid hormone, to make sure that the patient does not have hyperthyroidism.
Mm-hmm.
Yeah.
Were there any association between hyperthyroidism and hyperprolactinemia?
I can't remember, so I have to go through the notes again.
Oh, okay. Then other person who Fez Okelo. Fez, can you hear?
Sir,
So what's the essence of doing this test?
we said to rule out renal failure because in hyperprolactinemia, the serum creatinine and BUN, the levels are high because they are not excreted efficiently. So to rule out the renal failure.
Okay, thyroid function test.
To rule out thyroid disease.
Okay, is there any association? Is there any association between thyroid disorder and high level of prolactin?
I think because they are all regulated by the pituitary gland. So maybe someone can take over.
Yes, it seems like some of you are not really like capturing the most important key information. Okay, is there any other person who is willing to try?
I think.
Okay, Fabian.
I think it's because in primary hypothyroidism, more thyroid-releasing hormone will be secreted, which will increase TSH as well, and then the TSH increases secretion of prolactin.
Yes, that is why we need to assess the thyroid function is primarily because there is an association between primary hypothyroidism and high level of prolactin. So when there is low thyroid hormone level, it activates the anterior pituitary. So this TSH can actually even increase the production of prolactin, prolactin level. Renal is related to clearance. Okay, good. Then I think the treatment goal is straightforward. Then maybe what are the treatment options we're having to manage this condition? It's very simple and straightforward. Treatment strategies. Maybe Sylvia. What are the treatment strategies for this patient?
To normalize the prolactin level.
Oh yeah, that's the goal of therapy, but the treatment modalities.
We could surgically remove the tumor.
Surgical resection of the tumor, one strategy. Any other? But does she have any tumor?
Yes.
Where is the tumor?
The pituitary tumor.
Yeah, 9 millimeter in diameter. Okay. Surgical approach can work. Yes, but it is not the primary like treatment modalities. Why it is not the primary treatment modality?
Because it doesn't jeopardize her visual acuity.
Exactly. Okay. So we do have surgery is an approach, but it is like the last resort. but we usually start pharmacological treatment options like dopamine agonists. Okay, good. So this is all about, by the way, hyperprolactinemia. Hyperprolactinemia. Any questions so far?
Sir?
Yes.
There in that study, it says that she's having infertility because she stopped her contraceptive medication 8 months ago, and she hasn't yet been able to conceive. Can you say it is a sign and symptom for the hyperprolactinemia?
Yeah, yes, by the way, yes. I forgot even that one. That is because, of course, oral contraceptive, by the way, can delay, like the Depo-Provera, the injection, the implanon, like that can be implanted subcutaneously. So those one, they can actually even delay, like for the normal cycle to resume and for a mother to conceive. There is a probability of delay. But when you look at this condition, she has been taking oral contraceptive, but oral contraceptive, the probability of delay at such long time is very, very unlikely. So this inability to conceive is more of related to hyperprolactinemia as compared to the use of oral contraceptive. Good observation, by the way. Yeah? Did I answer your question?
Yes, you did. Thank you.
Okay, good. Now we're going to we're heading to dwarfism, growth hormone deficiency. Yeah, I hope you have encountered maybe in your lifetime very short people. So those people are not short by nature. They just like because of a deficiency of growth hormone. So there is something wrong in the pituitary. So is there anyone who encountered like extreme deviation from the normalcy in terms of height? Have you encountered any very short people?
So what is the limit of height for you to classify someone as extremely
Yes.
short?
Yes. Okay. In fact, you can guess what is the limit, but you have to look at the age. So in short, when you say dwarfism or short stature is a condition that is commonly defined when the physical height is greater than 2 standard deviation below the population mean in a specific age group. So that is normally the standard definition. So if, for example, if a person is actually age of 20s and if it is 100 centimeter, that is actually like that is like a deviation, even it is more than like 2 standard deviation from the height. So depending on the age group, you can actually even estimate. So if there is a deviation by 2 standard deviation and below the population mean, we can say the patient is most likely having a growth hormone deficiency. So is there anyone who came across very, very short individuals? Anyone? You didn't came across in your lifetime so far? I think you did at least once. Huh? You did that? Okay. But anyways, that is how...
There were 2 people who were acting a couple of years ago.
Oh,
they were
like...
called
Oh,
brothers.
Oh, they are actually like twins, huh?
Yeah.
Okay, but do you have like information about like, do they have any problem with the family members, like any genetic disorder, or you don't know? You just only know them physically, yeah?
I don't know them past that.
Oh, okay, fine. Huh? Oh, so anyways, it's very rare, but still you encounter those cases, huh? Yeah, by the way, you'll encounter those cases, huh? Okay, anyways, now let me take you through about growth hormone deficiency. The most common etiologies are usually congenital growth hormone deficiency. So this is something related to inheritance from the mother or maybe due to uterine development. Then severe head injury tumor in the head and any history of pituitary tumor, that means they are affecting the anterior pituitary to produce the hormone. Maybe, of course, if there is an infection, any brain surgery, those are some of the things you can actually encounter to be dwarfism. So hormonal problems related to the hypothalamus gland or pituitary gland can also, and even radiation treatment to the brain areas can actually cause dwarfism. So in short, when we say the pathophysiology of growth hormone deficiency, it exists when the growth hormone is absent or produced in inadequate amount. That is how it happens. So the deficiency can be congenital, as I mentioned before. It can be even acquired, maybe after birth, or it could be results from the disruption in the hypothalamus pituitary axis. I think those are like self-explanatory. So if there is any problem that can be acquired, it can be a disruption from the HPA axis and etc. So ultimately, in case if it occurs in children, there is actually a failure to have a linear growth, what is expected during the specific age group. So this is childhood growth hormone deficiency is actually almost universal to cause a linear growth problem. So they are actually very, very dwarf. I think that is the most common. So you will see significantly the effect in children because of the effect on the bone growth. So when you look at the clinical presentation in children, when you look at the clinical presentation in children, they are become below the average height, they slower than the normal growth. Then remember, growth hormone is very important for muscle like mass. Poor muscle development is very, very common. And we have mentioned about the physiological role of growth hormone. It is very important actually to increase the sugar level when we are in the stressful event or when we are actually in the fasting state. So it is very common counter regulatory hormone. So the patient can have even a low sugar level in the blood. Then delayed puberty or delayed onset of puberty, I've already mentioned about like growth hormone is important for development of all organ except for maturation of secondary sexual characteristics. That one, there is a need of gonadotropin. Then abnormal obesity and is very common. This is related to the metabolism. Then reduced velocity and delayed skeletal maturation and failure of linear growth is very common. So those are the most common typical presentation when a child is having growth hormone deficiency. Then when you look at in adults, reduced bone density. Remember, growth hormones are very important by the for bone formation. It has both osteoclastic and osteoblastic activities, but the net effect is mostly for bone formation. So it is very important for bone growth. So the patient can have even like reduced bone density, and ultimately you will see osteoporosis, and fracture of the bone is also very common. Decreased muscle strength this is related to the effect on the protein metabolism. Then, as we mentioned, even the fat is usually high. Remember the effect of what we call growth hormone on the fat metabolism is usually degradation or breakdown of fat is very common. So that is why is not if the patient is actually having deficiency, you'll see increased fat and even high cholesterol level is very common in those patient population. Of course, it can even affect the growth of the cardiac function. So ultimately, the patient can have even impaired cardiac function. So those are the clinical pictures when a patient. So in adults, by the way, you might not see any problem the linear growth because already the growth plate is already closed. But in children, you will see those are the most prominent clinical presentation we can see from the person, failure of linear growth. Then when you look at the diagnosis of this growth hormone deficiency in children, the physical height that is greater than 2 standard deviation below the population mean for a given age and gender, that is one diagnostic criteria. The patient will exhibit a growth hormone level of less than 10 nanogram per ml following a growth hormone stimulation test. By the way, this is the most common test that can be conducted to assess whether a certain individual is having growth hormone deficiency or not. And mostly the glucagon, the insulins are the one, they're supposed to be actually injected carefully because they can actually increase a risk of hypoglycemia, like insulin when you give them subcutaneously or intravenously. Mainly if you give them intravenously, the risk of hypoglycemia is very high, but those are the most common growth hormone stimulation tests. The moment you give them insulin, because of the effect on the glucose level, the patient can be actually have low sugar level. So that low sugar level can actually stimulate the release of growth hormone from the anterior pituitary, so that we can measure, and we call it growth hormone stimulation test. So mostly it is less than 10 nanogram per ml in children after stimulation. Then the level of IGF-1 can also be reduced. That is very common finding when a patient is having this problem. And apart from that, growth hormone deficiency can be occur along with other pituitary hormone problem and even hypoglycemia as well as hypothyroidism can also be noted. Remember, if there is a problem that maybe because of tumor or because of maybe infection, if there is a problem in the pituitary gland, the patient can have even any other pituitary hormone disorder, such as hypothyroidism also, and also even hypoglycemia. Then CT scan can be done. So this one is just to detect whether there is any structural defect or developmental anomalies. So we can do CT scan of the head so that we can see whether there is any problem in the brain development. The growth hormone stimulation test usually is less than 5 nanogram per ml. So if it is less than 5 nanogram per ml in adult, this one is diagnostic for a low level of growth hormone in adults. Remember, even look at the lipid profile. We have seen the role of growth hormone is just for lipolysis, but when there is a deficiency, you will see increased LDL level and even low HDL cholesterol level is significant finding when a patient is having this problem. Then I've already mentioned about reduced bone mineral density is also common finding when a patient is having this problem. Okay, so those are the most common diagnostic modalities that can be considered to rule out whether the patient is having dwarfism or growth hormone deficiency in short or not. So then what is the goal of therapy? The goal of therapy is to correct any clinical symptom the patient is having, maybe if it is weight, bone mineral density reduction, and even high cholesterol level and etc. So to maximize the final adult height, especially in children. By the way, with growth hormone treatment, we can actually even maximize the height of the children every year. And mostly with replacement therapy of growth hormone, like 10 centimeter height is expected every year if the patient is responding well to the treatment. So to achieve this normal physiological growth hormone level in adults and to reverse any metabolic abnormalities and any other decreased quality of life can be restored. That is the goal of therapy. So the current treatment we're having in the market is the growth hormone replacement therapy. Whatever the cause, we have seen about the causes, but whatever the case, if the patient is actually having growth hormone deficiency, the only treatment modalities we can consider is growth hormone replacement therapy. So this is the main pharmacological treatment approaches in for a patient in both for growth hormone deficiency in both children and adults. So they can actually even promote skeletal, visceral, and general body growth. In short, they can actually even stimulate protein anabolism. So and affect this even bone, fat, and metal metabolism. And mostly, by the way, growth hormone therapy can be given on the daily basis, either subcutaneously or intramuscularly. And as I mentioned in the previous lesson in the introduction, growth hormone production is mostly carried out at night time. Like 2/3 of the growth hormone secretion is usually carried out when we are in sleep. So because of this reason, mostly the growth hormone replacement therapy is usually recommended to be given at night time so that we can mimic the physiological production of the hormone. So we do have so many growth hormone analogs, and all of them are equally effective. We can say they are therapeutically equivalent. So what kind of doses or how much doses of replacement therapy we can consider? And mostly a small dose like 0.02 to 0.05 milligram per kg subcutaneously can be recommended. So remember, if we give this dose, we can actually even increase the height of the children, like before the closure of the growth plate, we can increase at least 10 centimeters every year with replacement therapy of growth hormone. So those are the products we're having in the market. So this is the brand name products we're having in the market. So in summary, how do we treat growth hormone deficiency in adults? So mostly this is the recommended doses when a patient is having growth hormone deficiency in adults. 0.1 to 0.3 milligram per deciliter. Then after 1 month of treatment, we have to check the insulin-like growth factor 1 in the serum. Then we titrate the doses upwards up to 1.25 milligram per day. Then 6 months later, we have to actually check the response. If there is no response, there is no need of replacement therapy of growth hormone because of the risk. I will actually mention later what is the risk of continuous replacement of growth hormone therapy. Then, if no response, by the way, you have to discontinue and treat maybe underlying causes. If there is adequate response, you monitor the IGF-1 level in the serum. So, in short, this is how we are treating growth hormone deficiency in adults. So, what are the key factors about the growth hormone therapy? So, in general, we have to start with low dose, as I mentioned before, then we gradually titrate upwards so that we can reduce the possibility of potential adverse drug reaction. Then, when we discontinue the growth hormone therapy in childhood, deficiency is usually controversial. So it is just up to the level. So in short, it is reasonable to continue growth hormone replacement therapy until the child has reached a satisfactory level of adulthood or achieved documented epiphyseal closure or growth plate closure, or if the patient until the patient failed to respond to the therapy. So this is the general recommendation, but still, how long we are going to continue the treatment or when we are going to discontinue the treatment is controversial in childhood growth hormone deficiency. So far, the optimum duration of treatment is not clear, but most clinicians, or based on the expert opinion, lifelong therapy can be recommended. So that is the general recommendation. But if you don't see any response, with the treatment, with the growth hormone therapy, and if you don't see any benefit, you have to discontinue the treatment like 2 years after therapy. That is general recommendation because of the possible adverse drug reaction. Then what are the major ADRs related to growth hormone deficiency? Growth hormone replacement therapy is there is a possibility of edema. Even the patient can have benign increase in intracranial pressure, maybe alteration, concentration, or visual changes are also very, very common. Then apart from that, there is a need to be very cautious when you are replacing growth hormone therapy. So far, there is no evidence about the association between risk of malignancy and recombinant growth hormone therapy. However, if the children is having any history of malignancy, they have to be wait for at least 1 year free period. For adults, it's just 5 years before initiating growth hormone therapy. So, despite there is no clear evidence about the association, if the patient is actually having history, they have to be wait at least for 1 year free period from the malignancy before we initiate the treatment. Then, if the patient is actually having active malignancy, growth hormone treatment is usually not recommended. Then, any patient treated for a prior malignancy may be at risk of secondary malignancy and should be monitored carefully for tumor recurrence. So, if a patient is actually already treated before, we have to actually monitor because the probability of recurrence of secondary malignancy due to the growth hormone treatment can happen. Those are the general recommendations you have to know as far as these replacement therapies are concerned. Then, how do we monitor the response? For children, we usually monitor every 3 to 6 months. This is the general recommendation. So we have to check whether they have added height and any change in velocity is very important. Then after adult height is reached, maybe we can discontinue it like at least for 1 month. Then we actually reassess so that we can actually treat based on adult growth hormone deficiency diagnostic criteria. So in summary, when a patient is having growth hormone deficiency, give them subcutaneous daily dose of replacement therapy and then you monitor the response. If they do have active malignancy, make sure to avoid any growth hormone replacement therapy. Any questions so far? Any question?
A question. Since you're giving them the hormonal therapy until like under monitoring, are there cases, is it possible for someone to exceed now overgrow, or that doesn't happen, or maybe after cessation of therapy, because it's just hormonal replacement, they shrink back? Is there such a scenario?
Okay, but the major problem with endocrine disorder, the moment you discontinue, like as long as the pituitary gland or as long as the organ is not functioning well, as long as the gland is not properly functioning, the moment you discontinue the treatment, like after a few maybe weeks or few months later, it will come back normal. That is why continuous or lifelong replacement therapies monitoring is very important. But of course, if you replace excessively, there is a possibility of actually having ADR as a result of excessive growth hormone replacement therapy. So both ways can happen. If you replace excessively, you'll encounter like the excessive effect of the growth hormone. If you actually discontinue the treatment, you'll encounter the symptom will actually come back again. So both options Both options can happen. Okay, then let's see about shortly pan-hypopituitarism. So I hope you know what does the word pan-hypopituitarism stands for.
So I have a question.
Mm-hmm.
Why don't you give growth hormone in malignancies?
You know, the major problem, growth hormone, they can actually increase the growth of everything, every organ, including even the cancer cell. So if the patient is actually active malignancy, means the moment you give them growth hormone, those are actually very good signal even for the malignant cell to reproduce or to replicate themselves. That is why we don't give them when a patient is having active malignancies. Because how? Yes.
Yeah.
Okay, then pan-hypopituitarism. So pan-hypopituitarism stands for a condition with a complete or partial loss of anterior and posterior pituitary function. So this is actually due to various causes. So in short, if one and more of the hormones are significantly deficient in the serum, we can say the patient is having pan-hypopituitarism. Remember, it can be complete or partial. Complete means all pituitary hormone. Partial means maybe some of the one end and above. So this is when we say pan-hypopituitarism. So when a patient is having this condition, they will encounter deficiency of cortisol, then gonadotropin deficiency, growth hormone deficiency, and even hypothyroidism. So that means all types of anterior pituitary can be deficient. Then in case of primary pan-hypopituitarism, remember the word primary is referring to the problem from the gland itself. So if there is a problem within the secretory cells of the pituitary gland, we call it primary pan-hypopituitarism. If it is secondary, it is usually due to lack of proper external stimulation needed for the release of pituitary. That means it could be from the hypothalamus. So that is when we are going to say secondary. Then what are the major causes of pan-hypopituitarism? When there's a tumor, when there's a necrosis, it is just due to surgical trauma, due to radiation therapy, or due to any CNS infection. So those are the major causes of pan-hypopituitarism. So how do we treat pan-hypopituitarism? Mostly we are going to consider replacement therapy. So mostly, like we have to assess what is deficient in the serum. Then after that, we just continuously give lifelong replacement therapy in most of the cases. So that is why assess the specific hormone, then replace it accordingly. So replacement therapy can consist of glucocorticoids, thyroid hormone preparation, and even sex steroids can be considered, even including growth hormone. So this is all about the anterior pituitary disorder. I just picked like what is very common. So now in the next 10 minutes, because we started late, like 10 minutes late, because most people did not join, I think I have to pay now. So a disorder of the posterior pituitary function. So remember, the posterior pituitary gland only produces antidiuretic hormone as well as oxytocin. So most likely, we are going to see today, are going to see any problem with the posterior pituitary hormone. So we have mentioned about the vasopressin and oxytocin. I don't want to mention again, and you know the physical role of vasopressin is just for water retention, and oxytocin is mainly for milk ejection as well as for contraction of the uterus during delivery. Those are the principal function of this hormone in the body system. So when a patient is having deficiency of antidiuretic hormone, the patient will have a condition known as diabetes insipidus. Don't confuse with diabetes mellitus. Those two things are actually different. So this one is, we call it like water disorder, but the other one is related to the sugar. So when a patient is not producing sufficient level of antidiuretic hormone, which is very important for the absorption of water in the collecting tubule, the person will actually produce a lot of urine. We call it polyuria. So maybe for today, we're going to see diabetes insipidus. So this diabetes insipidus is usually characterized by production of large volume of diluted urine. So why the urine is diluted is because ADH is not able to absorb water from the collecting tube, so the person will actually undergo a lot of urine. So it's very common, like passage of large volume of urine above 3 liter per 24 hours, and it is very diluted based on the osmolality of the urine is the most common finding. So remember, the normal urine osmolality is between 300 to 900, but if a patient is having diabetes insipidus, then the volume of, the osmolarity of the urine will be less than 300 millismol per kg. Then what are the types of diabetes insipidus classification? We do have two types of diabetes insipidus, central and nephrogenic. Remember, the ADH is produced centrally from the hypothalamus, and it is stored tentatively in the posterior pituitary, then it will act in the kidney. So this is how the normal physiological process can happen in the body system. Then, when we say central diabetic insipidus, the problem is decreased secretion of the hormone. But in case of nephrogenic diabetic insipidus, it is mostly not due to secretion. The hormone level is actually normal. ADH level is within the normal range, but the target organ, that is the kidney, is not responding. So it is just a problem related to the kidney. So mostly, it is very common when a patient is having chronic renal insufficiency, when they are actually having any electrolyte abnormalities such as high level of calcium, potassium, and even glucosuria. So in that condition, the kidney is actually refusing to actually do the action of antidiuretic hormone. So nephrogenic is resistance, this one is deficiency. So you have to know the difference between the two. If you are asked to differentiate between central and nephrogenic, central is deficiency of ADH, nephrogenic is resistance to the action of antidiuretic hormone from the target tissue. So those are the difference between the two. Then, when you look at the etiology of DI in short, it's mostly due to a reversible destruction of it is actually due to the destruction of the gland. If the posterior pituitary gland is distracted, the patient can have this problem. That is the most common etiologies. Then it can be due to congenital, acquired, or genetic disorders, some other causes, and even including surgery. So those are some of the etiologies that are responsible to cause this defect. Of course, even when a patient is having head trauma, maybe any metastatic type of cancer, such as lung and breast cancer, metastasis to the brain can also even affect. Even some type of hematological malignancies can affect, and of course, toxoplasmosis and viral encephalitis can cause this condition. So there are several causes which ranges from trauma to infection. Then some drugs can actually even cause nephrogenic DI, like the lithium, the tetracycline class of drugs, the amphotericin B, the antifungal, what we have seen the last semester, even the aminoglycosides, they are nephrotoxic because they are concentrated in the kidney, the cisplatin anti-cancer drugs, and electrolyte imbalances. So drugs can also even cause nephrogenic diabetes insipidus. Then polyuria is a common finding. When a patient is having diabetes insipidus or DI, polyuria is very common finding. So this polyuria is in frequency, and even sometimes nocturia is very common because the kidney is not able to concentrate urine at night time. So the patient can have even nocturia. Then as a result of a large, massive amount of water is actually losing or like excreting in the form of urine, polydipsia is very common, and even the patient can have dehydration. So those are some of the clinical parameter we can see when a patient is having this condition. Then diagnostically, how do we come up with the diagnosis of this condition? So the serum sodium level is high. So why is the serum sodium is high? What do you think? What do you think why the sodium serum is high? No?
I'm not sure, so.
Okay, read it.
I'm not sure. I don't know.
Okay, but then remember, it's only water is actually like losing from the body system. So if the water is actually losing from the body system, like what we call it dehydration, the serum level of sodium will be like the concentration of sodium will be actually very high. That is why the sodium level is high in the serum, because water is losing. Now we don't have actually sufficient amount of body fluid to dilute the sodium. So that is why the serum sodium is usually high. Then specific gravity of the urine is very low. Why? Because the urine is already diluted. Then serum osmolality is high because water is actually losing from the body system. Then urine osmolality is reduced. Why? Because the urine is diluted. When the urine is diluted, then the osmolarity will be reduced. So those are some of the things you need to know. Then when you look at the serum ADH, it is usually decreased, particularly in central ADI. When a patient is having central diabetic insipidus, mostly the patient will have what? Will have low level of antidiuretic hormone. Then apart from that, water deprivation test is very important to differentiate between central and nephrogenic DI. Then water deprivation test is usually given along with a desmopressin test. I think let me talk about this one, then I will end the session for today. Then water deprivation means you just actually deprive the patient for 8 hours. You don't give water for 8 hours, then 8 hours later, you actually give them what? Desmopressin. You give them desmopressin. Then, if the patient is actually having central DI, what will happen the urine osmolarity after deprivation? What will happen? If the patient is having central EI after water deprivation or desmopressin suppression test, what will happen to osmolarity of the urine? Anyone who can try?
It increases.
Why? It increases, I agree, but why it increases?
I'm not sure.
Okay, any other person who can try? Riha, can you try? Or Samiha or Riha?
Sir, I don't know.
Okay. Now here, when you say desmopressin, we are just giving antidiuretic hormone. Central, what is the problem with central ADI? The problem is deficiency, yeah? So the moment you are giving replacement therapy with desmopressin means you're actually replacing antidiuretic hormone. And the problem is not resistance, but the problem is actually what? Is deficiency. So now the concentration in the urine will be increased because vasopressin retain more water. So this is how we differentiate central ADI from central ADI from nephrogenic ADI. So in central ADI, osmolarity will be increased in the urine after the suppression test. But if the problem is nephrogenic, despite you give them desmopressin, the problem is not the issue or the level of antidiuretic hormone. The problem is the target tissue is not responding. So you don't see any change in the osmolarity of the urine from the baseline, or we can say reduce in the osmolarity of the urine is the major finding. So osmolarity increase in central EI, but the other side, the osmolarity from the urine will be reduced. So that is the major finding and how we are going to differentiate between central ADI from nephrogenic ADI. So any question? I don't know whether you captured the difference between the two in terms of desmopressin suppression test. Any question? Any question?